Good morning, everyone, and welcome to our Friday morning virtual tumor board. We have a really outstanding lineup this morning, and I think that you should find not only the cases enjoyable, but most importantly, the discussion that follows. We've got just an incredible panel joining us this morning. And for our tumor boards, I'm going to hand this over to the Master of Ceremonies, Dr. Mike Tuttle.
Thanks, Mark. Welcome this morning. As Mark said, we do have a phenomenal tumor board. The cases will come to us from McGill this morning, and we'll introduce Dr. Payne in just a minute. Let me just, we'll go around the faces as they are on my screen and have you say a sentence or two so we know who you are. Margie?
Hi, good morning. I'm Margaret Brandwein-Weber. I am Chief of Pathology at Mount Sinai West, and I'm a head and neck pathologist.
Awesome. George?
I'm Dr. George Coura-Filho. I'm Brazilian nuclear medicine physician at the University of São Paulo at the Institute of Cancer. And I'm also the president of the Brazilian Society of Nuclear Medicine.
Wonderful. Thanks for joining us. We know your center very well. Professor Shaha.
Hi, I'm Ashok Shaha. I'm on the surgical faculty at Memorial Sloan Kettering Cancer Center. And I've been doing endocrine fellowship with Mike Tuttle for the last 23 years. I still have more to learn.
Yeah, I'm almost ready to do a lobectomy. It's pretty soon. Eyal. Oh, you're muted, Eyal. Could you unmute there?
Hi, I'm Eyal Robenshtok. I'm an endocrinologist and thyroid cancer specialist from Israel. Hi.
Fantastic. And Bruce.
Yeah, hi, good morning. I'm Bruce Culliney. I'm a medical oncologist at Mount Sinai downtown.
Awesome. Welcome. All right, Rick, can you introduce yourself and then let's get started.
Yeah, thank you. I'm Rick Payne. I'm from McGill University in Montreal, Canada. I work in the Department of Otolaryngology Head and Neck Surgery. And before getting started, I'd like to say I have no conflicts of interest to report. I'd like to thank the THANC Foundation for inviting me to present these cases today. It's also a privilege to work with all of you, specialists, world experts on this topic. And so thank you. I hope that we have a great session together. And last but not least, I want to thank these individuals for helping put this together. As you all know, everything we do is collaborative. And especially at our center, McGill, this is how we do it. And so let's jump into the first case if everyone's ready. Please cut me off at any time if you have any questions or comments. It's a 53-year-old male who presented to the emergency department with chest pain that had been getting worse over 3 days. There was no notable past medical history, and he had no other complaints. On exam, there was a very obvious protruding mass over the right chest. The emergency physicians worked him up, and they did a CT scan, and then they called my team. And this is what we found. Does anyone want to comment on this, or should I go through this?
Go ahead and go through it for us, Rick, and then we'll talk about it once we get the initial presentation.
Perfect. So this is, as you see here, there's a mass coming through the chest wall, and that's what was protruding through the skin. And lower down, there's a cut here. You see the part of the thyroid. You see the trachea being narrowed somewhat. And then we have this, and me as a thyroid surgeon, I don't know this part of the body so well. I just had our radiologist tell us that this was in the right atrium or superior vena cava. And so on the reports, they tell us that there was a 6.5 centimeter right manubrial costal junction mass. As I showed before, something in the right atrium. And a big left posterior cul-de-sac mass. And of note, the trachea was narrowed at 7 millimeters, a thyroid goiter. In the vertebral bodies, there were many lytic lesions and lytic lesions in the left humeral head. And our expert radiologists we worked closely with had their impression of this being either sarcoma, renal cell carcinoma, and possibly an aggressive thyroid cancer. And so the team came down and did a core biopsy of the chest wall. And this is what we got. And this is just on higher power. It doesn't look like chest wall to me. It looks like something that I actually know what it looks like.
Let me pause for just a second. Go back for me. Margie, it's totally not fair to ask you to read slides off a video, but yeah, initial impression looking at this?
Well, so I know that's well-differentiated thyroid carcinoma, and I know from experience this could be a widely invasive follicular carcinoma, or it could be follicular variant of PTC.
And why did those two things come to the top of your mind, Margie?
Well, you know, it's okay. It's a very extreme, but yet classic example if it is follicular carcinoma, widely invasive follicular carcinoma. People, you know, even though this is part of the well-differentiated thyroid cancer family, it's you know, a thing that follicular carcinoma comes to diagnosis with a bone metastasis. Maybe not a metastasis protruding from the chest, but this is a known thing. And it's also a known thing that PTC follicular variant can behave like a widely invasive follicular carcinoma.
Yeah, so this is you're guessing from this presentation, lots of bone mets and that sort of stuff. We're going to have some sort of follicular lesion, probably with widespread vascular invasion, and that's what this is going to turn out to be. Okay, so that's what we're thinking. All right, Rick, where are we going?
All right, let's see. So we have our biopsy of the chest wall. This is the actual pathology report from Dr. Pusateri. He's one of our thyroid and head and neck pathologists at McGill. And you see here in red highlighted, consistent with metastatic well-differentiated thyroid cancer, as Marge was saying. And we do IHC, or we've been doing it for a couple of years now, just looking with a BRAF stain. And it was negative for BRAF. We also do a Ki-67. I don't know if all institutions are doing that right now. We do that fairly regularly now, just have an idea of how aggressive it is. And for us, a Ki-67 less than 5%, we're happy with that. 10 to 15% is a little bit aggressive, nothing crazy, but a little bit.
Right, it's beyond what's normally expected.
So, Eyal, following on what Margie was talking about, are you surprised this is not BRAF, or what mutation would you be guessing here? I mean, I thought all of these bad cancers were BRAF and tall cells. Does this surprise you here, or are you okay with this?
What's interesting is how we change our mind as things go along. So at first, if we've known it's thyroid cancer beforehand, we would have thought about anaplastic thyroid cancer, about poorly differentiated thyroid cancer, because it's so aggressive. We would need some more information about the history, how fast everything happened, if we could get some information. But then we saw the biopsy, and on the biopsy, we saw follicles. We didn't see solid pattern. We didn't see anaplastic cells. We saw follicles. It looks like a thyroid. And this is when you, like Margaret said, it looks like a well-differentiated thyroid cancer. And then you think about other mutations, especially RAS mutation, which is typical to follicular or follicular variant. And it causes us to be slightly optimistic about the chances of radioactive iodine, because if we see follicles, there's some production of thyroid hormones. So maybe we can be optimistic about some efficacy of radioiodine.
Okay, all right.
Mike, yeah, so I just also want to add, something like this, you also have to think about, you know, Pax8 PPAR gamma rearrangement, because, you know, that's what you see in follicular carcinomas with angioinvasion, and you can see it in these tumors.
Yeah. So I assume, Rick, you biopsied thyroid. Let's go ahead and see what that looks like.
Wow, you knew it. So next thing we do, we brought our ultrasound machine down and we did an ultrasound guided biopsy of the thyroid, and we saw a 3.5 centimeter solid thyroid nodule. We use TIRADS scoring regularly, and it was a TIRADS 4 in the thyroid. And the biopsy showed papillary thyroid cancer, follicular variant, same as what was on the chest wall. We're routinely starting to rely more and more on molecular. It's been a few years now, and we're starting to get somewhat accustomed to it. And as expected, the BRAF stain was negative, or the BRAF, there was no BRAF mutation, but there was an NRAS and a TERT mutation that was uncovered.
Which is not surprising, right? This is following along what Margie was talking about before, and Eyal was talking about follicular lesions, RAS base with the TERT. Bruce, traditionally oncologists always had to wait last in line, and everybody else took care of him. Then we gradually came to you guys. This guy's got disease everywhere, and I'm going to come to Dr. Shaha and let him tell me about the surgery. But is there a role for oncology up front in anything like this, Bruce?
Well, I think it can always be discussed. I think I think the mainstay generally would be surgery if that's an option. I think for well-differentiated tumors, I mean, we do have options with kinase inhibitor therapy that may shrink the tumor or give some benefit. But I still think that it often, if surgery is in the plan or is feasible, it doesn't often make surgery less, and that's really a concern. I think if there was any issues where surgery was need to be delayed or something, it's something that could be considered for buying time. But I'm not sure that we can say that it often leads to less of a surgery. So I think it always has to be decided if surgery feasible at this point.
Yep. George, part of the decision making in what we do or don't do always is what's the likelihood that radioactive iodine is going to be helpful, right? He's got big disease that needs to be taken care of, but from what you know right now, do you think there's going to be a role for radioactive iodine in part of the process somewhere?
Well, I think maybe if you consider removing the thyroid, I think radioiodine would be considered. But I think at the present time, maybe an FDG PET-CT upfront would be interesting also to evaluate how active the glucose metabolism is and to predict poor prognosis.
Right, and would help you understand likelihood of RAI avidity and likelihood of Bruce having to be involved. Because if we had 1,000 places with SUVs of 30 that were really high, that may rethink, right? Ashok, obviously everybody's thinking about surgery on this one, but before you talk about the surgery, he's got Mets everywhere. I mean, when you look at that big picture, how do you think about getting him started and then headed towards surgery?
I think that's a great question. And one of the things we need to see and decide is, number one, he's a young man, he's 54. So we cannot just say, it's a big difference between 84 and 54, number one. Number two, probably this disease has been there for a long time. That's why you got sternal met. For some reasons, follicular cancer with a vascular invasion or a capsular invasion, I don't know what is the link, but the sternal mets are not uncommon in thyroid cancer. They are rare, but you do see 2 or 3 cases a year. And when I saw this picture first CT scan, I knew this was thyroid cancer. Yes, you do need to distinguish between renal cell or sarcoma. But when I saw the details of the CAT scan with a big mass in the thyroid, there was no doubt in my mind this is thyroid cancer. So the first important question is, number one, can I resect this satisfactorily? That is number one. Number two, am I going to give more morbidity to the patient, which may be post-operatively difficult to manage? 3, can I take out all the tumor? And the other thing which is very important, and Mike, you mentioned, he has diffuse metastasis. But those diffuse metastases are unlikely to be detrimental at this time, unlikely to be lethal. What is going to be lethal in this patient's care is the growing of the thyroid tumor and the sternal mass, which will fungate through the skin in future, and the thyroid tumor invading the trachea, at which time airway will become a catastrophe. So should the surgery be considered? Absolutely yes. Obviously, you will need multidisciplinary group, especially with the superior vena cava metastatic disease, and you need to get a thoracic consultation. What can they do to do the best surgical procedure? So my recommendation is do a wide and handsome surgery, do the appropriate reconstruction, be prepared with the family to understand the risk and complications of the operation.
Okay, Rick, take us through your treatments, and then let's get up to radioactive iodine. We'll pause and talk a little bit there.
All right.
Mike, just a quick thing from the audience. We have a question circling back on Ki-67. I think this probably goes to Margie. With respect to the aggressiveness of tumor mitosis or the Ki-67, in terms of whether or not this is pointing towards poorly differentiated?
Yeah, yeah. I routinely do excuse me, Ki-67 and P53, although I don't, rely on it as like religion. But if both are elevated, then it may be below, the threshold for poorly diff, but it still points to like the possibility of grade progression, or as Rick said, more aggressive within the category of well-differentiated thyroid cancer.
Awesome. Thanks, Margie. Okay, Rick, go ahead.
All right, and thank you. Great discussion. So during the workup, the patients start to develop pulmonary emboli, and that's not so uncommon as we learned when you have cardiac mets. And so we started him on anticoagulation, and pretty quick we brought him up at our tumor board, which is, as I said before, the one thing that I hope everyone out there picks up is treating thyroid cancer patients is really, really, truly multidisciplinary. Our endocrinologists, our thyroid surgeons, our pathologists, and nuclear med physicians, oncologists, as you said before, more and more, everyone. And so we discussed the treatments. As we said before, we could go palliative with radiotherapy. He's got mets all over the place. I think survival with cardiac mets is very, very low. And there's also, for us, we didn't feel that there was a molecular mutation that we could target with targeted therapy because it's NRAS. On the other hand, we discussed, because as Ashok was saying, the patient's young, so consider surgery with radioactive iodine and possibly external beam, because this is, in fact, seems to be well-differentiated thyroid cancer. And we know, at least in our experience, we look at TERT not as an aggressive mutation locally, but as a mutation that allows, it's an open passport to the body. So it opens up everywhere. So, and that's what we've seen with our TERT, and we have a fair amount of experience with that. So that's how we look at it, an open passport to go wherever it wants. But it's the NRAS that's going to drive the tumor. And so we opted for surgery. And the patient opted for surgery after the long discussion with the family, and expectations were discussed. And this was August 2020. We did a total thyroidectomy, neck dissection, excised the metastasis, and we decided that we'd follow with external beam radiation and I-131. And this is what the thyroid tumor looked like. It looks like well-differentiated thyroid cancer. Marge, just correct me if I'm wrong, or if you want to.
You're doing well. You're doing well.
Oh, this is clear vascular invasion. I'm not sure who mentioned that before, but this is the type of tumor, as you can predict, it's in the chest wall. So there's going to be somewhat vascular invasion, and this. And look at the right atrium mets. This looks like well-differentiated thyroid cancer. A medical student not long ago bought me a pair of socks, and they are a histology slide of thyroid cancer. And this is what it looks like, the follicles. That's what it is.
Looks like the socks.
And here's a chest wall metastasis as well. So in faunal pathology, there was a large papillary thyroid cancer follicular variant with extensive angioinvasion, not many lymph nodes. And as we know with RAS doesn't tend to spread to lymph nodes, at least in my experience. The right atrium and SVC masses were large. It was the cardiac surgeon who removed that. We started our surgery with the cardiac surgeon on pump, and then the thoracic surgeon, and then I did my bowel thyroid. So I tried to be the quarterback here, but it was really the cardiac surgeon and the thoracic surgeon who did all the hard work. And a 13.5 centimeter met to the ribs, and one had 2 lymph nodes positive. And following that, we immediately gave external beam to the spine and iliac crest for those mets. And we do, I don't know how others do it, for the radioactive iodine, in these kind of cases, we like to give 3 doses, a fairly good amount over every 3 to 6 months. And so that's what we did. And here's some pictures. And
pause there for just a second for Rick. So George, they did the surgery. The tumor came back exactly as Margie predicted 15 minutes ago, right? This is a NRAS, TERT positive vascular invasion. So no surprises here at all. These often do concentrate radioactive iodine, as Eyal said, so we're on the right page. So we still have Bruce on the sideline here for a little bit in this one. There's always a question about how much of the big stuff do we need to resect? How much can you kill with radioactive iodine? Can you talk about sort of how much surgery needs to be done before you do radioactive iodine in these distant mets, or what you're thinking about that?
Well, I think whenever you can do mostly the excision of the larger masses, it's better because you expect a better response to radioactive iodine when you have smaller lesions. We know that very large lesions, especially those large lesions that do not concentrate very well, can have a decreased response. Or if they have an extreme uptake, they can still uptake from the other lesions. So whenever possible, we try to remove surgically the larger masses. And in this case, I think it was very well done. We see in the post-therapy scan that the size of the mats are the usual, many bone mats spread through the skeleton. Not all of them concentrate radioactive iodine very well. Some of them have mild to discrete uptake. So we have to keep an eye on these lesions. And what we do here in the Cancer Institute in the University of São Paulo, we do an upfront larger radioactive initial treatment with 200 millicuries of radioactive iodine for bone mets, but we do not follow a schedule of subsequent doses. We always try to evaluate how well the patient responded before deciding for new radioactive doses.
Eyal, what's your approach to, when do you retreat these guys? Because obviously we're unlikely to cure him, but you will get shrinkage. So what's your sort of plan for retreatment?
So first, looking at the images that we're seeing now, it's amazing to see in such an aggressive disease, to see such a strong uptake in some of the metastasis will drive us to give significant doses of radioiodine until we don't see any uptake. Now, there are two approaches. There's the approach of giving the maximum the first time and then evaluating. And there's the French approach. They give 100 millicurie repeatedly until there's no uptake. So we usually try to give a large dose to begin with, 200 millicurie. And if we see response, we give it again. This patient is probably going to need, high chances is going to need systemic therapy in the future. We want to get every bit of efficacy we can from radioactive iodine, which is much easier, much safer treatment. So at least twice with 200 millicurie, and then we'll see how we responded and the thyroglobulin, and during follow-up, we'll decide if we give more.
Perfect. Okay, I need a couple of one-sentence answers. There's a few things that come from the crowd before we come off this case. George, there's a question about, this guy obviously got external beam radiation and radioactive iodine. Efficacy, who goes first? Would you rather give radioactive iodine first? Do you do external beam radiation? How do you sort of sequence that in about 2 sentences?
Well, there was a myth that external beam radiotherapy would decrease uptake from radioactive iodine. In my experience, the cases I used EVT before did not decrease, so I have no preference.
Okay. Ashok, very quickly, you talked about wide and handsome, and I thought you were talking about me. There's a question about clear margins. When you say
yes, not wide.
Okay, I heard the wide part.
Okay,
there's a question. Yeah.
You know, somebody asked a question in the chat box about the positive margins. Remember, this patient is going to have positive margins everywhere. there is a myth between, there is a big difference between squamous cell carcinoma and thyroid. Thyroid positive margins mean very little. What is more important is, can the surgeon tell you, I took out all the tumor? There is no surgeon who is not going to have a positive margin in thyroid. One margin is the muscle. One margin is the air in the operating room. So don't worry about it. What you need to know from the surgeon is, did I leave any gross tumor behind?
Perfect.
That is
All
very
right, I'm
important.
going to answer two quick questions and we're going to move on to the next case. One was, does the molecular signature drive the extent of surgery? And I'm going to say no, that was driven by all these other decisions that we talked about. And Dr. Coben asked about maybe using dosimetry in cases like this, because sometimes you get this diffuse lung uptake that you can hurt the lungs. So we can either do dosimetry like we do, or just use your initial diagnostic scan. If that initial tracer diagnostic scan doesn't show that diffuse uptake like you see in kids, then I don't really worry about too much to the lungs. Okay. All right, Rick, let's jump ahead to the next case.
Mike, just one point about molecular signature. I think we're not using this today in the clinical practice, except anaplastic BRAF and a RET PTC. I think we have some data now that the RET PTC may make the tumor shrink a little bit and the surgeon may feel a little better to do the surgery. But otherwise, I don't think we are using that. Our clinical factors are so strong that the molecular signatures are not going to make any decision today. But I think we are in the right track to learn more about it.
Okay, I'm moving on. Give me the last word about, there you go. Let's go, Rick.
Last patient doing very well, traveling back and forth to New York, pre-op TG high, dropped, and now we're going to follow and treat accordingly. Thank you for all the important advice and comments, and let's go to case number 2. Case number 2 is a 56-year-old female, non-significant past medical history, 2019, had a left 1.5 centimeter TIRADS 4 nodule. As per, we like to follow the TIRADS recommendations. We did a biopsy, came back as Bethesda 2. As per most of our practices, we'll wait 1 to 2 years for another ultrasound just to see if there's change. And the nodule increased modestly to 1.9 centimeters. We did a biopsy and, sorry, we did an ultrasound FNA, March, and we got this. And so it was called Bethesda 3 by one of our cytologists or pathologists. And for this, some of us routinely do molecular testing. It came back as an NRAS with a lowish allele frequency. And the report says around a 50% likelihood of malignancy, which we often see with that. Our understanding or the way we treat this is these NRAS tumors at this point may not be malignant, but over time it's a transformative process. So eventually we do feel that this will eventually become a malignancy, either follicular carcinoma or a well-differentiated thyroid cancer, follicular variant. And so in July, did a hemithyroidectomy. I routinely do sentinel lymph node biopsy, as Mark Urken knows. That helps me find anything that may be unusual, and I know where it's going to spread. And so I find that blue node in the central compartment.
Pause just a second there, because this is a continual battle between Dr. Shaha and I. Go back once. Professor Shaha, sentinel node biopsy, Delphian node, what do you really do? This is a lobectomy RAS tumor. So what would you really do here?
I just gave a eulogy to sentinel node biopsy. We don't do that. And again, I'm not against Rick. I think what he was trying to do is to try to find out if there is any obvious lymph node. And that's what we do. What is important, the debate about prophylactic central compartment should come to an end, because the principle is a good central compartment evaluation, which starts with good ultrasound, good CAT scan, and good evaluation at the time of surgery. If you find something abnormal, suspicious, nasty, I would get a frozen section, which essentially what Rick did. He did the sentinel node with some dye or some other technology, and I use my eyes. Again, is there a big difference? No. What is important, again, I want to stress to the audience that it's a good central compartment evaluation, and if there is anything abnormal, take care of it same time.
And at the time of your lobectomy, Rick, you didn't see any gross disease or any gross lymph nodes that you could identify?
No, and Ashok brings up a great point. Not at all. And the only thing that sentinel lymph node biopsy helps us, it actually gives us an area to focus on in that central compartment, because I don't like to disturb that central compartment too much. I like to evaluate with my fingers if I have to, but that blue line, and we just use blue dye, so it's a little methylene blue. It takes less than a minute, and you follow the blue line, and often a blue lymph node just pops up. We take that out and we send that.
Okay, so let's go ahead. So you went ahead with the lobectomy?
Yeah, and we got follicular variant of papillary thyroid cancer. This looks fairly clear-cut based on one slide. I know it's not the entire specimen, but we had a surprise. And Marge, do you want to comment on this area here in this lymph node?
It's a beautiful example of ENE. If you're on the upper left quadrant of this slide, you can see it's breaking through a rather thickened capsule, and CNE, extranodal extension.
Which for us was a very big surprise, because with RAS tumors, as I said before, we don't see metastasis like this. And this is just a high power view of the lymph node metastasis.
Yeah, so here I would be a little concerned if you just go back, because you are seeing these large cells that don't look like PTC. Now, I'm assuming that this came from a frozen section. So, you know, there's distortion that's introduced because the tissue's been frozen. But when you do see those large nuclei, even if they don't have nucleoli, it's telling you something more is going on.
And then we routinely, as I said before, we stain the lymph node for BRAF, and it was positive.
Holy cow.
And
Dr. Robenshtok, how big was this lymph node, Rick?
Oh, small. It was 4 millimeters.
4 millimeters. All right, Dr. Robenshtok, BRAF, tell me what's going on here. So we got an NRAS tumor that was taken out. You got a little lymph node. Holy cow, what are we going to do here?
So first, probably it's a pretty common scenario, because multifocal papillary thyroid cancer is pretty common. Central neck metastases are pretty common. If you do molecular analysis of each foci in the thyroid and each lymph node, it's probably going to be heterogeneous. I don't know what to do with these results. So I don't know the genetic variation. I'm not sure if it means anything. I'm not sure if it's more aggressive or not, because we haven't looked at it before. So it's a new thing. And as long as these things are so small, the things that Margie said are worrisome, so I would treat more. But if everything is very small, I probably would ignore it, as we'll discuss next week, and I'll stop here in the session.
Margie?
I do want to say that the combination of no extrathyroid extension and a positive lymph node, that's highly unusual, and almost well, it happens very rarely. So, you know, you have to ask, like, what else is going on?
Yeah. So Margie, if this is my mom, I'm sure Rick had his pathologist go back and stare at every slide to see if there's a papillary microcarcinoma on the left side. There wasn't. So does she have disease on the right side? Does she have another thyroglosal duct? Does she have an ovary? Where's her primary thyroid cancer? You have to guess, Margie. Does she have thyroid cancer on that other side?
I would say, you know, you have to rule it out.
Yeah. Dr. Shaha, does my mom have thyroid cancer on the other side?
Probably yes. I think the last, you know, in the slide there is a red line there, lymph node therefore not related to primary tumor. I think that again we don't use molecular markers, but here you start thinking, and Margie said it very well. In an encapsulated tumor, to find the extranodal extension is very rare. So you start thinking, is there something on the other side? Should I go and take out the other side? Will that tumor become life-threatening to the patient? I think those are important issues.
Now, Dr. Robenshtok, what Professor Shaha would really do is he probably wouldn't even offer a surgery to this lady. We would carefully look at the other side. We would do an ultrasound. We'd do a CT, and we might tell her not to treat that. Does that make any rational sense at all?
So the problem today is we look at everything as a continuum from low risk to intermediate to higher. So here, primary tumor looks low risk, but we have a lymph node metastasis and we have extranodal extension, I think reluctantly I would send the patient to a completion thyroidectomy, but then think again. I'm not sure I would have gone further to radioactive iodine. We'll see what happens later.
Professor Shaha, you have to be honest here. So would you do a completion thyroidectomy, or would you walk the patient over to my clinic and say, how about the two of us just watch this person? What would you really do here?
You know, both the choices are very appropriate. I don't think it is wrong to watch this patient and intervene if and when necessary, if the ultrasound shows something or the paratracheal area shows something. But knowing that this is BRAF positive, again, we don't use that as a decision maker, but you start thinking globally. There is something more going on here. There is another primary tumor that I'm missing, which is BRAF positive. So probably it would be appropriate to do a completion thyroidectomy and clean up the central compartment, make sure there are no other lymph nodes with extranodal disease, which may get plastered against the trachea, and do the best cancer operation as long as the patient can handle it.
Now, Rick, what if I argued that we know 60% of papillary microcarcinomas are BRAF positive? They don't mash against the trachea. They don't get out of control. If this was a 5 millimeter papillary that we knew was in the other lobe, we might actually offer active surveillance. So do we, I mean, I just worry that we're about to really over-treat this lady. So how are you guys, I mean, I know everybody's going to do a total thyroidectomy, but how are you guys sort of thinking about that?
So I think you asked me, so things for us, Lisa, are changing based on the molecular, and of course, size is important for tumors, but we're starting to realize that size doesn't matter as much as we once thought it did. And even though there's going to be a small micropap on the other side that's going to be BRAF positive, leading this lymph node, we know that this BRAF, and not all BRAFs are the same. I think there's other mutations we're missing. I think there's an epigenetic component that we're missing. But this BRAF tumor, no matter how big it is showing that it's a bad one, an ugly one that's able to, even though it's tiny, it could send this little lymph node, a met to a little lymph node with extranodal extension. As such, for that reason, again, not all BRAFs are the same, but given this information, knowing that it made an ugly lymph node, I think we're inclined to remove the other side, which is what we did.
Mike, can I just ask a couple quick questions? In terms of risk stratification here, how do we differentiate between minimal extranodal versus gross extranodal? How often do people see skip metastases from one side of the thyroid bed to the other, which is really what we're talking about here. So let me just throw that out there.
Eyal, you want to grab a couple of those?
Yeah, so this tumor, this patient would be very simple if we wouldn't have done the molecular markers. So we would have thought there's a tumor, there's a lymph node, and that's it. Now, because of the molecular markers, it's more complicated than before. Maybe it's common, we just don't know. We need to do these studies.
Yeah, I mean, so yeah, the microscopic extranodal extension that literature was just developing when we were writing the 2015 guidelines, because remember that was written in like 2014. So if I had to redo those now, there's no question that extranodal extension would fall in that kind of intermediate group. And it's definitely gross extrathyroid extension from any sort is different than the microscopic. So it's on that continuum of risk. Skip mets are incredibly common. That when you look at the old data, they used to say it was only like 20% of the time, but that's before folks were doing really aggressive central and lateral neck dissection. So the thyroid cancer can leave the thyroid from either side, go to the other side, go to the middle, go to the opposite side. So there's a general pattern of right being on the right, left being on the left, but nothing you can really hang your hat on.
I just want to say one sentence. The reason in my eye to do a completion thyroidectomy is the pathology report and not the BRAF mutation. Many of the low-risk thyroid cancers are BRAF mutated. So this is not what's driving the decision.
That's the caution. And if you look at where BRAF is shown to be important, it's always superimposed on the anatomic pathic staging. Distant mets with BRAF is worse than distant mets without gross extrathyroid extension. So as Eyal is saying, even these small ones, it's kind of hard to know. Now, to be fair, they're all treated, right? So all we know is the treated experience of these small ones. All right, I want to get to an anaplastic case. Rick, keep going for me here.
All right, so I'll finish up quickly. We did a right completion thyroidectomy. It showed micropaps, BRAF positive in one of them. Patients doing well, thyroglobulin dropped, no antibodies from 61 to less than 0.1. And we chose to watch at this point and not give radioactive iodine. Does anyone disagree with that? And should we give radioactive iodine? Any comments?
George, what are we doing? What do we do down there?
Yeah, first, just one comment. I found it funny that the product of the initial surgery, the lymph node, was from a sentinel node biopsy. So we would expect it was from the place he injected, not from the contralateral lobe. So I thought this was funny. Well, in this case, we have a biochemical excellent response. So it would be okay to some people to consider a low radioiodine activity treatment with maybe 30 millicuries to have a more, let's say, a more precise post-staging. But I think maybe it would be unnecessary.
So it certainly wouldn't be mandatory. And I think the majority of times, once we've seen that other lobe and there's nothing worrisome in that other lobe, it wasn't an aggressive tumor in the other lobe, and the post-op TG was okay. So I think the primary reason to finish up your surgery was for sort of really a better understanding of the histology, right? So now we have a good feel that this is not low risk, it's sort of low to intermediate risk question. There was one question that came in from the audience that said, if we were doing active surveillance and we found a new lymph node met, would that take us towards surgical intervention? And the answer is yes for right now. Because that, as Rick was saying, that would be saying that is one of the papillary microcarcinomas that would be indifferent. Now, to be fair, I do have a few that somebody biopsied a little 3 or 4 millimeter lymph node, and I tell them not to watch, and they say, yeah, I'm watching anyway. So Ashok refers to this as outside the box. So to be intellectually fair, we know these papillary microcarcinomas have lymph node metastasis 60% of the time. So if somebody finds a little teeny one, but the reality is if they have lymph node metastasis, they're not going to be in an active surveillance program. Okay. All right, let's do the last one, Rick. That's it. Those are great cases. Let's talk about more. I want to get Bruce involved here with some like stuff that's really may actually hurt somebody instead of us hurting people. Go ahead, Rick.
All right, case number 3, a 70-year-old female presents with a very hard neck mass on the left side, level 3, level 4. It's been progressing significantly over 3 to 4 weeks. No sign of infection.
Hold on just a second, Rick. Ashok, Dr. Shah, you guys say this all the time. It's a very hard mass. It's a very worrisome mass. But I always hear about that like after you know the pathology. When you're seeing them the first time, is there something really different about these things?
Yeah, the hard mass, fixed mass are always concerning. The number one, we need to get a good diagnosis. Whether it is related to her previous thyroidectomy, I don't know. It was benign. So you start thinking that this is a metastatic cancer unless proved otherwise. And the second thing is, where is it coming from? A needle biopsy will direct you, is it thyroid, non-thyroid? If it is non-thyroid, you do the endoscopy like any other unknown primary. There is a primary in the oropharynx, hypopharynx. If there is a strong suspicion that this is non-thyroidal, we would do the HPV, which is very common in the United States today.
Yeah, and Rick, do you sort out hard from fixed? I mean, you guys sometimes use the word fixed. What do you mean when you say the tumor is like fixed on your physical exam?
Fixed means it just won't move. It's not going to move at all. It's going to be in one hard place, kind of like trying to move a stone that's attached to the ground.
Got it. Okay, so keep going.
When we use the word surgically fixed, it is fixed to the deeper structures. And when I use the word fixed, means technically it may be either not possible to resect or resect with a concern.
Gotcha.
So that's the word fixed. Hard, fairly common, not uncommon.
And fixed should probably suggest gross extrathyroid extension or
Absolutely.
something, right?
Absolutely.
Okay. Okay, go ahead, Rick.
All right, so we, as Ashok mentioned before, the patient had a right hemithyroidectomy years ago and a left parathyroidectomy years ago. Important to note that the vocal cords are mobile. And here's the ultrasound that I did quickly. And this is just to orient you, this is the carotid artery here. This is the trachea. Here's a thyroid mass. And you don't appreciate so well, but this is the irregular fixed lymph node or mass that we see on ultrasound. And I'm not sure about all of you out there, but we really like to do our own ultrasounds on just about every single patient that we see now. It's part of our.
And you can tell this what you call the lymph node mass was clearly discrete and different from what you were seeing in the thyroid. Those were two different lesions.
Absolutely, and you don't appreciate the separation here, but I really wanted to get the carotid and to show that it's lateral to the carotid.
Gotcha.
And so I encourage everyone, if you have an ultrasound, please use it. And if not, learn it and use it because it really ends up being a great tool preoperatively and postoperatively.
Rick, the CT scan will be also great help.
Yeah, you'll see it in a moment.
Don't forget cross-sectional imaging in any thyroid suspicious nodule or a large tumor.
Okay, guys, let's go ahead and do the presentation here, Rick, and let's get up to the diagnosis so we can talk about the treatments there.
Okay, so it's a TIRADS-5 thyroid nodule on ultrasound with a 4.4 pathological level 3 lymph node. Here's the CT showing the thyroid mass. You don't see it so well. It's nothing too worrisome. Then you see this large necrotic-looking neck mass. And here you see just a different view of it, of both masses. There's some chest metastases, or what looks like small little chest mets. And the CT report showed a 1.5 centimeter left superior thyroid mass, the lymph node. You don't see the IJ. The left common carotid is not encased with, as Ashok mentioned before, that's a very important distinction to understand whether it's encased or not. And tiny pulmonary nodules. The FNA came back as PTC. Our pathologists sometimes, and they're pretty good at this, sometimes give us an inkling, just a suspicion of tall cell. They never make the diagnosis from a biopsy, but they say, you know, some cells look a little bit off, could be a tall cell-like. Margaret's shaking her head.
I said it's a trigger for me. It's a trigger.
We will avoid triggers. And we'll go to the lymph node. And the lymph node, again, with our ultrasound, we do very aggressive biopsies. And here, any triggers here, Marge, or is this clearly?
I'm good.
So the level 3 lymph node is anaplastic thyroid cancer.
Yeah, and it's anaplastic.
And so for the thyroid nodule, this was the ultrasound guided biopsy report, just saying papillary cancer could be a possibility of tall cell or columnar. And the level 4 lymph node is positive for BRAF. And look at the Ki-67.
Yeah.
It's at 25 to 30%. So it's, for us, that's sounding off alarm bells.
And P53 being negative is does not exclude the possibility of anaplastic. That's why I say, you know, I routinely will do K67 and P53, but I don't hold it religiously, you know. So I've made the diagnosis of anaplastic being P53 negative.
All right. Mike, do you want to take over here? You want me to stop at this point, or should I continue?
Yeah, so let's do surgery first, and then we'll talk to Bruce about, you know, anaplastic and BRAF. In fact, let me go to Bruce first. So Bruce, so we got a papillary thyroid cancer inside the thyroid. We've got an anaplastic that's BRAF positive in a lymph node. And all of this data now about BRAF and MEK inhibitors and who goes first in surgery. How would you be thinking about this case, Bruce?
Well, I mean, I think anytime you have an anaplastic cancer, you have to with that's BRAF positive, you have to, you know, at least consider whether or not surgery should be first, or if you should start treatment with dabrafenib and trametinib, because I think we know over the last couple of years the great responses we see with, you know, the drugs with or without immunotherapy. So I think it's always a consideration. I think part of it, just like with any anaplastic cancer, it also depends on resectability, you know, at the time of at diagnosis, whether or not it's really, do you really need to start, you know, treatment, medical treatment, or you go ahead with surgery first. So I think if it's resectable and doesn't involve any major structures or vessels, then it's reasonable to do upfront surgery. But if you think we know we can get, with so many patients, we get so much benefit from initiating treatment first. So I think it should always be discussed. And it's between, the whole team has to make a decision where to go first. I think it's, this patient, I think definitely has treatment from me coming.
Yeah, absolutely.
I should be pre-op or not, or I don't, I think surgery is reasonable based on everything we've said.
Ashok, help me understand, because many of these anaplastics are not resectable, and then they go straight to Bruce. Ones like this, I think Rick has made the case, it's not encasing the carotid. This is probably technically resectable. It may not be a lot of fun, but probably resectable. Operate now or try to make it shrink? What are you thinking here?
I think, in the past, I would have said 3 years back, I would have said operate, because I can operate on the patient. But I know at the end of the operation, I'm going to be very frustrated and unhappy, knowing the response that we have been seeing on anaplastic, our own cases. I think I'm very excited with the BRAF positive anaplastic to treat them with the new targeted therapy. And you can make a decision in 4 weeks. Because if the tumor shrinks in 4 weeks, I will probably go for 3 months and then operate on the patient. Will the surgery will this have major impact on the long-term outcome? I don't have the answer. But would I feel more comfortable with the surgery? Absolutely, yes. No, and I'm saying this based on other cases that we have done.
Hey, Bruce, the one thing that worries me, we know that the BRAF MEK inhibitors shrink the vast majority of these anaplastics. But what if this is a patient that it doesn't shrink and we miss the boat? If it doesn't work, this could go to unresectable, right? So
exactly, and that's actually a point that we bring up for this in many cases when you talk about a neoadjuvant approach. You may lose resectability, so I think that always has to be considered. And in this case, I think again we have many cases where it's not even a question. For many anaplastic, it's BRAF positive. I think the vast majority we're going to go with upfront treatment with me. But I do think it's a very good point, and that's one reason I think it's reasonable to do surgery if it's feasible with morbidity and so forth.
Absolutely. So Rick, they always call me the most aggressive surgeon at Memorial because I'm not the surgeon and I'm not the patient, right? So I can be very valiant. I'd pull you over to the side and say, look, can you get this out of there? I know what's technically resectable, but do you think you can get 99% of this out of here now? So how are you guys thinking about surgery versus the upfront BRAF MEK?
So the discussion here is almost, it's echoing what we discussed at McGill with our team, the same specialties discussing, always looking at what's best for the patient. The surgeon saying, you know what, you do so well with your anti-BRAF and MEK inhibitors, let's start there. And then the endocrinologist or medical oncologist say, well, if you can cut it out, we'll see what happens. And so it's amazing how things have changed through my practice past 15 to 20 years. And so we did feel it was resectable. We did take it out. It went, and we really did have good imaging, which showed us, and I felt with our ultrasound, with our CT, we could get it out safely with the patient. And it went well. And here are the slides. It ended up being a tall cell in the thyroid with the metastatic ATC. That's just invasion. Here's are all the stains, PD-L1 positive. And the final pathology showed a BRAF positive tumor, PAX8 positive as well, PD-L1 strongly expressed. Only 4 to 23 lymph nodes positive. The ATC, as was mentioned before, it was fixed. It was massively invading the muscle everywhere. We got a pretty good resection. We think we got most of it out, but there's for sure some microscopic, probably a little bit of gross disease. And so then we go to the next point and the final point, and the TG, interestingly, but not so surprisingly, pre-op wasn't very high, the thyroglobulin, because it was so aggressive. It forgot how to express the thyroglobulin, obviously. And so post-op, we can't rely on it too much. We suspect that there's something in the lungs right now, which we see on PET scan on the right and left side. So bilateral lung metastases. And so our current plan right now and this is all fresh, right to the original. And our discussion was, do we give radiation, radioactive iodine, or go straight to targeted therapy? And that was a big discussion after the surgery, knowing what we dealt with. And after a long discussion, we figured we'd treat the primary site with IMRT because we can really ensure that any gross or microscopic disease is taken care of. Our plan right now is to follow with I-131 as per our protocol, starting with 150 and then going once everything is gone. But if it doesn't respond to the I-131, if we don't see any take up, then to go straight to targeted therapy so we don't miss that window in the lungs.
Yeah. So Bruce, help me out here a little bit. So I'm trying to figure out when to get you involved and when do we go with systemic therapy, right? Because you're going to have 6 weeks of IMRT, then they're not going to feel like swallowing for a month or two after that. Now they'll get the radioactive iodine. We're going to be 3, 4, 5 months down the road before we figure out whether these lung things concentrate. So how do you integrate into all that?
Well, I mean, I'm concerned, with this case. It's an anaplastic, so we know that this patient could be in trouble sooner than later. So I do think I agree totally. Radiation with doctor is very reasonable, and that's what we would do for most of our patients after surgery for anaplastic. So that shouldn't change. I'm not sure how. Again, I leave that to the team. But as far as the radioactive iodine, yes or no. I don't think it's unreasonable to consider targeted therapy now, as soon as that is done, as soon as possible, even including, because this patient has a very high chance of recurrence and death from anaplastic thyroid cancer, I think. So I think targeted therapy, even considering with immunotherapy, Pembro, which seems to give you a longer progression-free survival, is a reasonable approach.
Yeah.
So I would say as soon as possible, I would consider it. I would discuss it for sure.
Yeah, I would too. George, what are you thinking up front in terms of timing radio? Because he's got a well-differentiated component as well.
Yeah, I think timing as planned is quite okay. I think the main concern is local recurrence from the anaplastic thyroid carcinoma. So radioactive iodine can be in a second plan. The thing is, there was small lung mets. And sometimes we see CT that does not even show the nodules and have a radioactive iodine concentration. So in this case, before planning radioactive iodine therapy, maybe I would consider a pre-therapy scan. And maybe if it does not show any uptake, I would consider treating focused only in the anaplastic thyroid cancer.
Yeah. So look, we're winding down the end. I think our approach would be when we start the IMRT, they almost always get a repeat FDG PET scan as part of that staging. So that's going to give you a 2-month gap, right? December to February. If the lung things are rapidly progressing, then Bruce is on and we're not doing radioactive iodine. If they're stable, we do CT scans again when IMRT ends. And again, if they're progressive, Bruce is on. If not, it's radioactive iodine. So this is not somebody that just sit back and watch for a long time, because if those lung mets are anaplastic, they're likely to change in just a few weeks. And I think there could be some good logic, as Bruce said, for just upfront Pembro or targeted therapy. So that would definitely be on the arranged form there. So let's answer a few questions from the audience before we finally down. Mark, was there a couple more on there from the audience about any topic that's still out there?
Yeah. I actually am not seeing anything that is terribly significant that we haven't covered in some form or not here. So I think we are good. I have one quick question for George. George, does the SUVs on those lung nodules was not very high? Can we take any comfort in that, or is that irrelevant?
Well, I think one problem is the size of the nodules. We can have an effect of partial volume, and we are measuring lower than it really is due to the small size. 9 o'clock. So I would not take comfort relying only in SUV.
Here's my last two commercials before we end. We'll have the good Dr. Robenshtok back next week, and then Dr. Clayman. And then just a quick announcement about the World Thyroid Congress. Next slide. We will be participating in that in TIRO. That's coming up. Next slide. Keep going. There we go. So to put that on your schedule, you can sign up online. You can find it at the World Thyroid Congress. It's right at 9 o'clock. Let me thank the panel. You guys did a great job. Difficult cases. Rick, thanks for organizing this for us. These are great cases to discuss, buddy. Have a great day. Thanks, Al.
Bye.
Bye-bye.
Thank you.
Take care,
Take
everyone.
care.
Bye.
Thank you very much.
Thank you, everybody.